So thank you for inviting me on. We're here to talk about ADHD and TMS. TMS is something that many people don't know about it, so I'll be happy to introduce you to it. And it's something very fascinating and interesting that we've been seeing over the last few decades, gaining FDA approvals in different areas. Back in 2008, FDA approval for depression. And most recently, we've seen FDA approvals for obsessive compulsive disorder, for nicotine addiction, for bipolar depression, as well as for migraines. Myself, absolutely maximize the screen, excellent. So I'm a psychiatrist. I've been working in Cyprus for the last 6-7 years now. I was trained in London. So I'm a director of Cyprus TMS. It's a TMS treatment center that offers TMS treatment and ketamine treatments for patients, as well as regular psychiatric assessments for different psychiatric disorders. I'm also a clinical assistant professor of psychiatry at the University of Nicosia and a PhD researcher in terms of using TMS and ketamine at the Maastricht University. Actually, I'm doing a PhD with the Netherlands over there. So let's start. So I assume that most of us here in this room, we know what is ADHD, it's a neurodevelopmental disorder. We see a persistent patterns of different characteristics such as inattention, impulsivity, and hyperactivity. You don't need to have all three, but perhaps we can talk about ADD when we have difficulties in inattention, for example. It's one of the most common childhood psychiatric disorders. The prevalence is around 7%, which is something quite high, I shall say. I'm actually looking for something that I can use perhaps as a pointer. At least I might be able to call it a different findings so people can actually think about what we're talking about. And according to the National Institute, this disorder has actually the findings, statistics suggest it's between the age of 3 to 6. Usually it's diagnosed in childhood, but persists most of the time during adulthood as well. So what we tend to see in patients that they do suffer from ADHD, we can see something as we can per se say that it's a kind of core symptom. So some of these symptoms might be present in individuals affecting cognitive function. So we can see motor and interference with inhibition. So people might get distracted much easier, let's say, if it's to compare with someone who doesn't have ADHD. We see selective and sustained attention be affected. So these are the different characteristics where some of us with ADHD might have and some of us might not have. So it doesn't mean you need to have them all. We have difficulties with switching, timing processes, reward-based decision-making. So some might say that our executive function might be affected from ADHD. So we might need to think about what are the ways, what are the different ways we could use to train our minds, either with medication, therapy, or perhaps TMS we'll be talking about today. And don't forget that if someone does have ADHD, it doesn't mean that they have only ADHD. So there might be a comorbidity, let's say with oppositional defiant disorder, something we tend to see in teenage people. Some people might also suffer from moderate depression disorder, also with anxiety disorders, tic disorders, Tourette syndrome, substance abuse. Sometimes what we tend to see people with basically are suffering from ADHD, they might try to self-medicate with stimulants. They might try to find different ways of helping their brains to function in a better way. So they might end up using stimulants or other substances. Also, we might see sleep disorders, and perhaps sometimes people's IQ can be affected. If we are having severe disorders, severe ADHD, for example, in a patient, the IQ might also affect at times. So different types of ADHD. we have the type which is predominantly affecting the inattentive presentation in terms of like what the person is experiencing. We have the type of hyperactivity and impulsive presentation of a patient with ADHD. And sometimes it's not as anything else in life, it's not black and white. We can have a combination of the two. So what causes ADHD is the $1 million question, and perhaps we're not certain. We have different hypotheses, we have different findings that are suggestive of different things. So some of the etiology perhaps lies on the genetic predisposition, brain injury, perhaps exposure to different kind of chemicals like lead. Also, there are some findings in the literature suggesting that if mother is a smoker, she does smoke, there might be a risk of developing ADHD, premature delivery, alcohol consumption, we're talking about abusing, especially alcohol, premature delivery and low birth weight. These findings were suggested by Sharma and others back in 2014. So we're trying to figure out what is actually going on with ADHD. We're trying to figure out, as scientists, as doctors, as psychiatrists, what is going on in someone's brain who receives the diagnosis of ADHD. So literature and researchers, they have looked at so-called functional MRI, something that can actually study the functions of the brain at different times through the help of the magnetic resonance. And it has shown that there is underactivation of different cognitive domains, dependent areas such as frontal striatal and frontal cerebral systems. So we are thinking, or at least this study is suggesting, that these areas in the brain are underactive if it's to be compared with someone who doesn't suffer from ADHD. So right inferior and medial prefrontal and striatal regions during cognitive control have been shown to be areas that are affected. I'm talking about a bit of medical terms. So if you're not clear about something, or if you want me to try and explain in more detail about it, we can try and focus on something as perhaps someone might call a medical jargon or something. So the right dorsolateral prefrontal cortex, it's an area around here. So we've got left and right. So these areas are also involved during attention. So we need these specific areas in our brain that is kind of like related with executive function, as well as emotional regulation and emotional control. There is the bilateral superior prefrontal region, so a bit more towards the prefrontal region, which is associated with the working memory. The inferior frontal, parietal, and cerebral regions, during the time we process the information. For example, we see some underactivation of these areas, and also the ventromedial and frontal striatal areas during reward-related function. So we all know about the dopamine and this kind of like magical neurotransmitter that we all need to feel pleasure. So we can see the involvement here of the reward-related function.
Before you proceed, I guess you are telling about all these areas in the brain that are affected by ADHD. You are going to address them with TMS. Can you tell us about that later on?
Yes, of course. And that's why we're doing an introduction into this. Yeah. So we will bear in mind what are we trying to succeed if it's someone to use TMS, for example. Yeah. How specific can we be, and what means we can use today, what has been kind of like researching at this moment in time, and what we can completely think about in our clinical day-to-day practice. So basically, I'm involved in research, I'm involved clinically as well. So we can try and think about if there is something we can do in terms of today clinically. Yeah. Excellent. So far, what do we know? What kind of treatments are offered out there in terms of patients that they suffer from ADHD? We know about behavioral therapy, including training for parents, because most of the time I see people that they're reaching adulthood or adults. So a lot of the time their parents will be saying to me like, oh, we can't do anything, we cannot control his behavior, we are kind of like depressed, we're anxious, we don't know what to do anymore, nothing is helping, medications are not helping, and we're kind of like desperate. And there's a big question mark. What is out there? What can we do to help parents and their children as well? Because when someone is affected, a child is affected with ADHD, the whole family is affected with difficulties in their mental and physical health. So we should be able to address it as family, not just as an individual. Look at the individual's difficulties, look at the parents' difficulties, because perhaps when you try to explore and assess their parents as well, you might find out they're suffering from anxiety disorders. If they're anxious, they will kind of like transfer their anxiety to their children that they are suffering with ADHD, and they will make things worse. So we need to see everything as a system rather than just we have a patient or a child with ADHD. That will not actually help and treat the situation. So skills training for, skills training for everyone. Counseling can help, educational supports. Never forget like educational psychologists that they're out there in terms of like schooling, in terms of schools, in terms of outside school activities and how they can help children, and how to actually use timetable and support them throughout the day, not just during the schooling times. Medications, we tend to know, as being a psychiatrist, I prescribe every day this kind of medications to help patients with ADHD. We know about the stimulants. Unfortunately, Marina, some of them are not available in Cyprus, like amphetamine. So dexamphetamine is not available here. So maybe you need to push towards that direction. Why Adderall? I've got patients coming to me. I'm taking Adderall from States. I'm taking Adderall from the UK. We don't have Adderall in Cyprus. What do we do?
In 2006, when we looked at the government on medication, Adderall was actually approved, but there was never a representative to take it out to the point. Sorry, in 2006, when we actually lobbied the government for ADHD medication, only Concerta, written in Concerta, was approved at the time.
Sorry, yes,
and Adderall was actually approved. However, there was never a representative to take it up to actually bring it to Cyprus. So this is still pending and could be. So right now we just have and Concerta.
Actually, it's the same thing. It's methylphenidate.
And Stratera.
And Stratera. Yeah. We have methylphenidate, which is in the form of like a prolonged release, like the Concerta, and the Ritalin, which is the immediate release. We have Stratera, which is the atomoxetine. And off-label, sometimes we might use, for example, modafinil, Modiodal, or Wellbutrin, which is even weaker in terms of a dopamine kind of like agonist, or working with a dopamine, actually not exactly an agonist. But what is important is we need to think about Adderall, because we don't have it available in Cyprus. And I'm pretty sure that with YESI now, if different pharmaceuticals are approached, even from ADHD Cyprus, I think, obviously, I know what their priorities are. We all know what their priorities are. But that's actually something that it will actually keep them to push them and get dexamphetamine in Cyprus. There are many pharmaceuticals, actually. There are many representatives in Cyprus. They can import medications from Germany or from all over the world. And there are different representatives. They're different. There is also like a local one. There are a couple of them are local, or maybe even more. Exactly. So yeah, I mean, if they get approached and they're explained in terms of market research and how many patients potentially are in Cyprus with ADHD and they could benefit from Adderall or dexamphetamines in general, I think they will show interest straight away.
Okay, sorry to interrupt. It's indeed a good idea to discuss some other time medication on Cyprus and in Europe. So if you please want to proceed.
Yeah, sorry about that. So non-stimulants we can also use with atomoxetine, for example. We all know the side effects from medications, that they might decrease the appetite or having problems with sleep or other kind of like side effects that we receive from medications. And there is a big question mark about their limiter and longer term efficacy of this kind of medications in the long term, let's say. Okay, let's talk something about that many people don't know in this room. Or if anyone knows about TMS, could they raise their hand and say something about it? I'll be very happy. Anyone knows anything about TMS?
Yes.
Some people are. Does anyone want to tell us what TMS is?
Start with the back there.
Okay. You want to introduce yourself so I don't know you?
Yeah, hello. My name is Petro. I'm a psychiatrist. I worked actually with TMS since 2018. I was trained by Alexander Sack in Maastricht at the university, and I was working at the university clinic in Aachen for a few years at the polyclinic with Tim Pope. And we did quite a lot of TMS treatment, but not for ADHD. Yeah, it's repetitive transcranial.
Repetitive transcranial
magnetic stimulation. It's a nice thing to do.
Excellent. So
it's non-invasive.
Yeah.
It's a way of stimulating the brain with magnetic waves, certain areas of the brain.
Excellent.
Yeah.
Actually, Alexander Sack is my PhD supervisor. So,
but we also know it in Germany, and we are now on big studies regarding ADHD, and the big hospitals start to get the machines.
Excellent.
To figure out, because they figured out that maybe really we had the neurofeedback and promising thing, and now it's everybody asks for this one to see what happens. So please go on.
So I've been involved in TMS since 2016, and obviously we've got Cyprus TMS in Cyprus since 2017 that we started working with TMS. So it's a promising treatment. It can stimulate or inhibit different sites in the brain based on the frequencies that we use. It's relatively safe, and we will talk about side effects. There are minimal side effects, actually. It's cheaper if we try to think about how expensive the stimulants are in the long term. And the most brilliant thing of all, it can actually induce neuroplasticity. What is neuroplasticity? I think there is a slide to come and will tell us what neuroplasticity is about. But let's talk about TMS first. So, as we have said, TMS is a transcranial magnetic stimulation. Through electromagnetic induction, we use the coil, the Faraday's principle, that when electricity goes through a coil, magnetic pulses are induced, are created. Basically, it's a flow of small amount of electromagnetic pulses with weak electrical current and are passed through an insulated coil. So you don't have to worry about getting, I don't know, any kind of shocks from the magnetic pulses. So TMS uses these electromagnetic pulses to modulate the cortical excitability. So we can try and modulate and stimulate the neurons. We can get different neurotransmitters produced in different areas in the brain, like dopamine that we need. New synapses will be created, new connections throughout the brain. Imagine if you're going through one-way street and there is traffic, you're stuck there. Imagine there are like 4 different other ways. So you won't be able to get stuck and you'll be able to move around. So in the same way, the messages can move around from one brain region to the next. It's depending on the stimulation parameters. As I said, if we use high frequency TMS or high frequency TMS. So there is a huge list of different neuropsychiatric disorders here. There is literature there. For some, there is small evidence, low evidence, medium evidence, high evidence. There are studies to suggest that different symptoms of different disorders can be helped through the brain stimulation. There are systematic reviews and meta-analysis that they basically got to see different protocols, because it's not just you do TMS and that's it. It's the brain region that you stimulate, is the frequency, is the protocol, is the number of trains. There is a bunch of different kind of parameters that you're using, and you need to try and find the ideal that will actually use and help the patient with their symptoms. So different things, we stimulate different regions. For example, in literature, in Parkinson, we stimulate the motor cortices. So the areas of the brain that are regulating our motor movements. So what is dorsolateral prefrontal cortex that everyone is interested about, not just in ADHD, but in other neuropsychiatric disorders? It's an effective targeted area for stimulation and fundamentally can be used to improve different symptoms in different neuropsychiatric disorders. Crucial role also is the mesocortical limbic system and the serotonergic systems, which are involved in these areas. Involved in the executive and cognitive functions of someone's brain, also in terms of regulating the brain and decision making, as well as the inhibitory control when we're talking about the frontal lobe that we can either stimulate or inhibit. Next. Excellent. Let's talk about this magic word. I really like the word neuroplasticity. It's one actually of my favorite words in neuroscience. It's a term that, according to Kramer and others, can be defined as the ability of the brain to kind of rearrange its function, its structure, based on intrinsic or extrinsic factors. Extrinsic factors, for example, is TMS, stimulating the brain from an outside source. Using non-invasive therapies to stimulate the brain, the cerebral cortex, which offers different options for different neuropsychiatric disorders. RTMS is a therapy that actually promotes neuroplasticity. It can actually increase or decrease the cortical activity. So cortical is just the brain, cerebral cortices and how they work, basically our brains. Okay, let's see a video here about the procedure. There's a nice music in the background. I don't know if that will play or not. Designated area, a designated design room. We tend to use this chair in people that they purchase by venture. People may use if they want earplugs because it has a sound like MRI. Does not require anesthesia. Patients are with adult types. So you're placed in this specific pillow that can keep your head still. And the technician will try to define by stimulating your motor cortex, your left one. You will see movements on the opposite hand. You can see the fingers moving when you stimulate contralaterally to your right side, so that's left side, the motor cortex. So the amount that is required to get to see your fingers moving is called motor threshold. For each and every person in this room, we have a different motor threshold. So you will feel a sensation on your scalp like someone is tapping. So thereafter, the magnetic coil will be moved from the motor cortex to the lovely dorsolateral prefrontal cortex. Scientists believe that it's responsible for causing depression, but not just. There's a number of trains with intervals. And treatment sessions might last from 3 to 4 minutes, or sometimes even a few seconds, like 39 seconds. I mean, the technician can stop at any time if he wants the procedure. Okay, so let's see, let's listen to her.
Surface, a depressed brain looks much like a healthy brain, but inside the differences are unmistakable. During depression, the brain isn't operating at full strength in the area responsible for emotion. Think of it as the brain's emotional control center. The emotional control center delivers signals along the neural pathways to and from the areas of the brain that determine how we act, react, and respond to situations, thoughts, and feelings. In a depressed brain, they have become less active, or even inactive. In other words, signals that would normally regulate mood and emotions do not work properly in depression. This affects the brain's ability to naturally decode, evaluate, and react to what's happening around it. MagVenture TMS therapy is a safe, FDA-cleared, non-invasive treatment that uses short magnetic pulses to target the exact areas in the brain affected by depression, stimulating and strengthening these neural pathways. Like training a muscle, over time the inactive signals begin firing and reconnecting properly again, and thus restoring the emotional control center.
In the brain. All right, excellent. So similarly, we can see different regions in the brain, as if we go back to a previous slide, that are not working properly. So in the same kind of concept, can we use TMS to help these regions that are not working, are either underactive or overactive? So we will talk about in terms of like some research and some studies on a later stage. So let's try to think about the side effects of TMS. If it's to be compared with antidepressants or stimulants or medications, someone will say there is such a small amount of side effects you will get, or even someone will say I don't get any side effects. So it's a treatment option for patients when we mention FDA approvals. If we're going to go by the book and say FDA approvals for patients that medications were not helping, or if someone could afford to pay because he doesn't want to try any medications, that's a treatment option as well. But in the States, for example, if someone has tried one antidepressant and it doesn't work, their insurance could pay for the expensive TMS treatment that takes place in the States. So if it's to be compared with standard medications, seems to cause fewer side effects. Standard medications could actually cause sexual disorders, gastrointestinal disorders, sedation, blurred vision, dry mouth, etc. The most common side effects from our TMS is 5 to 20%. I experience a headache after the session, but what I tend to say to my patients, drink 2-3 cups of water afterwards and you'll be fine, because your brain has worked a lot and gets dehydrated. But if you drink some water, most likely you will not get any headaches. Discomfort at the site of stimulation, obviously you will feel a tapping sensation on the head with some of the facial muscles experiencing some minor twitches, but it's nothing to worry about. And the most uncommon side effect, which is less than 0.1%, is having spasm at the time of the stimulation. As you probably know, all stimulants and antidepressants might also lower the seizure threshold, so there is a higher chance of having a seizure, for example.
I have one question, because we are always careful how to promote something. And you were mentioning, you are now comparing with medication on the part of side effects, but I think there's not yet any research into, does it work without medication as a comparison with medication, like, you know, controlled research, double-blind, etc.
It does work without medications in depression, for example.
Yeah, for depression we know. Yeah.
Yeah.
For ADHD, we're now talking ADHD today.
Exactly. For ADHD, I will be very clear in the following slides. This is just an introduction on TMS and general aspect of things. So these side effects mostly are actually compared with antidepressants rather than the ADHD medications. But I'm trying to kind of introduce TMS to people because they're not aware of TMS. So in terms of like, for example, if you're having a comorbidity of ADHD and some other neuropsychiatric disorders, but we will get more specific in the following slides, then ADHD will come into play.
Yes, it's just that I'm careful because we have just 10 years behind us that people
You're absolutely right.
jumped onto neurofeedback and thought it was instead of medication.
No one said anything like that, and I won't be saying that today. I'm just saying about comparison of side effects, and in the next few slides, things will become clearer to the audience, I believe. So we spoke about the TMS approved treatments already, so we can move on to the next slide. Let's talk about TMS and ADHD now. I hope it wasn't such a huge introduction, but I believe that I wanted to get everyone on board to understand what I'm talking about rather than just introducing a few studies and few findings. Thank you. So a study done and published just last year. So I believe that in the years to come, there will be a lot of publications with TMS and ADHD. So in the recent times, we've got some publications on TMS and ADHD here that they were actually published last year. So limited evidence is suggesting in this systematic review and meta-analysis, if is someone to have 1 to 5 sessions of TMS or TDCS, mostly as we have explained this area, the dorsolateral prefrontal cortex. But in these sessions, it has shown that there is a potential to improve clinical and cognitive outcomes of ADHD. The findings did not support, Hans, that's you here. I think the second phrase here actually answers your previous question. Did not support using RTMS or TDCS of the dorsolateral prefrontal cortex as an alternative neurotherapy for ADHD. Larger multi-session studies are suggested in order to optimize the sites of stimulation or inhibition accordingly, and the actual stimulation parameters in order to help us understand more about how we could combine cognitive training in order to achieve better outcomes. We could also use brain stimulation, and at the same time, we could ask the person to do different tasks, which is amazing because there are studies also in Alzheimer's that shows if you're actually stimulating the brain with the TMS and you're actually completing different questions or different tasks, it can have an extra benefit. So perhaps for ADHD, that's something that could be studied further in research, that you can combine cognitive exercises with brain stimulation. So a narrative literature review on TMS and ADHD. Existing literature suggests that positive outcomes of TMS in the treatment of ADHD in children and young adults, including improvement in inattention, impulsivity, as well as hyperactivity. TMS use in children and adults based on the literature findings is documented to be safe and with minor side effects such as scalp discomfort and headaches. Also, larger scale studies are much to be in terms of being conducted to investigate its use in treatment medication refractory ADHD, which is something that perhaps could have a benefit, especially in children or adults that they cannot tolerate stimulants or other types of medications used in ADHD. Neurostimulation in treating ADHD. Results. Most studies focus on the stimulation of the amazing side of our brains, the dorsolateral prefrontal cortex, and an area that is actually associated with executive control. Increasing the excitability of the right dorsolateral prefrontal cortex and using high frequency on the left dorsolateral prefrontal cortex or low frequency could potentially improve ADHD symptoms. So we can either inhibit if we use 1 Hertz stimulation is actually not a stimulation, but an inhibition. If we use more than 5 Hz or equal to 5 Hz, then we talk about stimulation of the brain. However, in these studies, we kind of like illustrated here, there are some limitations like small sample sizes, heterogeneous study populations, and also heterogeneous outcomes. And obviously there are limitations, and we're expecting more studies to come out in terms of ADHD and TMS. So neurotherapeutics, another review from Rubia was published last year. As we have said and explained, TMS is safe. We all know that now, and that's something quite established. The majority of the studies conducted are small samples, a few sessions. So when we treat depression, we use 20 to 30 sessions. In a previous slide, we spoke about 1 to 5 sessions. So that's a very small amount of sessions. So I would say that bigger studies with a lot of sessions, maybe 20, maybe 30, maybe even more, will have potentially a good outcome. Studies using TMS have not been promising so far, because if you're trying to think about their small sample sizes, we have some reports of improving some outcomes, but we cannot overgeneralize these results. So, and we're expecting the research to grow and support us throughout this. We need more multi-session sham control RCTs in larger number of patients, particularly in pediatric ADHD, to more thoroughly test TMS effect using different protocols. That's from the published study in 2021.
Just to clarify, when we say 3 to 5 sessions, that's a round of treatment, right? So do we mean permanent improvement of symptoms?
Okay, so what we tend to think about as the reason we did this big introduction is to try and understand a few things about the brain. We need to bring neuroplastic changes to the brain. Neuroplastic changes to the brain don't happen overnight, and no one is using any kind of magic wands that can change the brain from day to next day. So what we're trying to help the brain is to create neuroplastic changes. Neuroplastic changes won't happen over the amount of 2, 3, 4, 5 sessions. We can see, for example, like someone improving, being less anxious, being more focused, but 1 to 5 sessions is a very small amount of sessions. We need more. We need more than 20 to 30 sessions to establish something. And this comes actually to another point, that what we tend to suggest to patients that they actually receive TMS for different reasons is to have a maintenance treatment for at least 6 months. So even if you do 30 sessions, you don't stop the treatment. We will advise minimum of 12 sessions within the next months to come, because neuroplastic changes continue to happen. So we don't want to stop stimulating the brain in any way possible.
Okay, great. And my second question is if you could tell us your opinion about combination with therapy.
For ADHD?
Yeah.
Shall we do that at the end, perhaps? Remember me, remind me. Yes. All right, so obviously we're looking on different studies here. The studies are from 2010 and 2020. We can see the N here. I know some of you are not scientists or clinicians, so I'll try just to point out a few findings on the slide. So number of patients, N. So in this study, there were 64 patients. And you can see the other studies, quite small samples, 10 to 15 or 52 patients. So what we tend to think about when as researchers, we do different studies, we aim for double-blind studies because the actual doctor or the researcher is blinded, also the patient, so you don't know if you're receiving TMS or sham, in order to help us understand that this is not just placebo happening, but the TMS is actually helping. So from 64 patients, there were some improvements in terms of clinical and cognitive outcomes. Okay, myself here is actually hiding the headline which talks about cognitive changes, but I'm saying it so you know what this kind of findings are. Excellent. Now I'm moved around. So you can see the cognitive findings. So there are some findings in these studies to suggest that we could see some clinical improvements in terms of different assessment tools, use, in terms of hyperactivity, impulsivity, inattention, in terms of what parents are telling us as well, in terms of rating by parents. So that actually tells us, oh, my child is getting better. Don't know if it's a TMS or it's something else. Also, an improvement in inattention, total scores, visual analog scales, inattention. So what it tells us, there are small studies, small samples. There's something there. I hope it grows. I hope in the years to come that ADHD at some point will receive FDA approval for TMS to be used. So I don't know if I can move around again. So we can see the title of the study. Yeah, now I'm moving around. That's good. No, not the slide. Excellent. So we've got the slide. So this is a double blind. That's brilliant because the double blind study is a randomized clinical trial, even better. 62 patients, 3 groups. We've got a group on the right prefrontal cortex. So right prefrontal cortex, the left prefrontal cortex, and a sham. Sham is a placebo. Basically, we stimulate with something very small, so people will think that they're receiving TMS, but they're not actually receiving any TMS. This study did not show any improvement in the primary endpoints. Significant improvements were observed in inattention and memory. Increased activation in the right dorsolateral prefrontal cortex, right parietal, right insula after treatments in the right stimulation group. It's a bit of paradox. Actually, we're stimulating the right side, and where in depression, we inhibit this side. This is based on literature findings. Basically, this is what the research is telling us. We don't know why, but for some reasons, our brains, if we do suffer from ADHD on the right side, perhaps we have, let's say, an increased activation. Increased right dorsolateral prefrontal activation was associated with larger symptom improvement in the right stimulation group. This study indicates that TMS is effective in modulating attention-related brain networks, and is a feasible technique that may improve attention symptoms in adults with ADHD.
Can I ask a question? I want to have that clear. So with this stimulation, you can either inhibit the part with low stimulation, or with a higher stimulation, with a higher pulse, you can stimulate the part. That's
amazing.
Right. Yeah, it's amazing.
And it doesn't mean that we always need stimulation.
Mm-hmm.
For example, what is well established, as we said, depression, we stimulate left and we can inhibit right. So the same purpose in depression, but different ways of doing different sides, either using inhibition or stimulation. Next one. Positive effects on repetitive transcranial magnetic stimulation, ADHD, crossover, double-blind randomized, sham-controlled pilot study. This is a small sample of patients. The number is not here, it's only 13. 2 groups, a specific beneficial effect on attention 10 minutes after a real TMS course. That sounds too good to be true, doesn't it? The post-real TMS attention score improved significantly compared to the pro-real TMS group. Mood and anxiety were not affected, either of the placebo group or the TMS group. A transcranial magnetic stimulation, a pilot study again, 9 young adults, 14 to 21, and adolescents, of course, right prefrontal cortex, 10 hertz. So we're actually here, Hans, we're stimulating the right side. Yeah. Where in depression, we inhibit this side. When someone will think stimulants will help in depression, perhaps, and stimulants will help also in ADHD. But this is something different here, we see.
And in anxiety?
And anxiety, we will inhibit as well.
Yeah, because anxiety is overacting in your brain.
Yeah, but in ADHD, we see overactivity on the right side as well.
Okay. Right.
We see underactivity of the right side. So 10 sessions course over 2 weeks in a sham control crossover. There was 1 week of no TMS between the active groups. TMS, as again, was found to be safe. No discontinuation due to adverse effects. There was overall significant improvement in the clinical global impression of improvement of ADHD scales. The change between active and sham did not differ. So alleviation, now we're not talking about treatment, we're talking about alleviating symptoms, improving the quality of life of someone with ADHD, perhaps. 3 groups, 43 drug-free adults, and free drug adults. They were not receiving any stimulants, so the effect was not on medications here. That's another good question that perhaps this small study can answer something. That it was used with patients that they were not receiving any stimulants, they were not receiving any medications. Real treatment was safe and resulted in significant improvement of symptoms. This was 3 weeks daily sessions, high frequency, 18 hertz. Imagine in depression, we use 10 hertz. So we go higher here. Previous study was 15 hertz or 10 hertz. It doesn't always mean more hertz better, but we're trying to see, optimize what's the best option that can give us the best results. This pilot study indicates that it's safe. We're talking about safety again because we go on a higher frequency. So perhaps higher frequencies can stimulate or can induce seizures, perhaps more than low frequencies. And we're talking about seizures, but also it can be used, there are studies in epilepsy, when we use inhibition, for example, protocols. This pilot study indicates safe, directed to the right prefrontal cortex for treatment based on EEG recorded within the first treatment session. Sounds too good again. First treatment session. And these are not my studies, so I'm not trying to prove anything. I'm just saying what other people are talking about. They established a novel biomarker composed of the alpha and low gamma power, which highly correlated to the magnitude and the clinical outcome. Clinical effects of repetitive transcranial magnetic stimulation when combined with atomoxetine here. 64 patients, 3 groups, RTMS group, 10 hertz, atomoxetine group. So there's a comparison here. RTMS plus atomoxetine. RTMS and the combination therapy are effective in improving care, symptoms, core symptoms, and executive function in people with ADHD. The combined treatment has significant therapeutic advantages over the single treatment groups. Compared with RTMS, the drug therapy has a better improvement in coding and lower GABA in this specific task that they were actually used. Lower frequency transcranial magnetic stimulation and attention deficit, 13 voice, 7 to 12. Now we're using 1 hertz. So 1 hertz is actually, what is 1 hertz? Inhibition. It's not stimulation. Limitations are small sample size, lack of control group and sham conditions, further trials to be included to increase the number of patients so we could know better if we could use this protocol in children between the age of 7 to 12 in the future. Those are the references. The presentation is available to ADHD Europe. If you could try and look around if you want and find more about TMS or the references and the studies we have used in this presentation.
Your presentation okay to share?
Yes, sure.
So yeah, I make a note and I will share it. Share presentation. Yes. I guess there are quite some questions because first I have a question. Sorry, yes, I'm the boss here, so I start. Wait, oh. I have a question. You're showing different results. Yeah. You're showing certain results. I think TMS is not there long enough to even know something about long-term results.
Actually, Anthony Barnes started in Sheffield back in the 80s. He's one of the founders, let's say, or the founder of TMS. So there is a lot of literature that goes back to the 80s. Obviously, the FDA approval for depression came out in 2008, sorry. So it's been already 14 years. So we know in terms of long-term effects that there have been no recognized issues in terms of using TMS in the long term, as far as we know so far. Nothing is certain in this life, not for anything.
Thank you.
Thank you. My question is about the age group. Do you have more efficiency if this TMS is used on younger or older people? Because I have heard, not for this, but generally speaking, that if you try to re-educate something, you'd better do it when the kid, let's say, is younger rather than when he's older. Do we have something similar here?
All right, that's an excellent question. We can try to answer it or partly answer the question. We know that during our development, during our, let's say, teenage years, or even before that in childhood, the brain develops very fast, very quickly. The brain increases its size, its function, in terms of understanding, perception, and everything, basically. We used to believe in the past that our brains are the brains that we received in our adulthood. And as we grow old, we might have atrophy or dementia, and we will die, and perhaps our brains will die with it. But now we do talk about neuroplasticity. I would say that it's never too late to induce neuroplastic changes to someone's brain. Perhaps a younger brain might be more adaptable to change rather to an older brain. But no one should be excluded, I shall say, from trying to train their minds and brains and what have you, physically and mentally. So never give up and never stop the neuroplastic changes to your brain.
Thank you.
I have a question too, if you don't mind. I'm not a doctor, so maybe my question is a bit stupid, but I've heard also of something called neurofeedback. Is it different?
It's completely different.
Okay.
Completely different. It's a completely different thing.
Okay, thank you.
Hi, Will here from Iceland. Earlier you mentioned the side effects.
Yes.
And you said the headaches 5 to 23%, and the discomfort in the head 20 to 40%. Now I actually know a little bit more, so I understand they may not be serious side effects, but the first thought was those numbers are higher.
Okay, so honestly, the high numbers, the discomfort, if I come to you and I tap on your head, for some, they won't like it. You get used to it after a few seconds. It's a minor tapping, it's a minor twitching of the facial muscles. So discomfort is very subjective as well. What I'm trying to say is we're trying to kind of like think about what the benefits could be from this by stimulating the brain. And these side effects, I will classify them as minor if it's to be compared with antidepressants, for example, that most of the people will complain of sexual dysfunction or difficulties with sex, weight gaining, dry mouth, something that we don't tend to see at all with TMS.
Something I know since I was diagnosed wrongly with depression before I got my ADHD diagnosis.
Thank you.
Also go to any questions from the Zoom chat at the moment. So if you want to put anything in the Zoom chat, I'll check that after our next question.
Yeah, I just wanted to say something about the age question before. I'm not a researcher in any way. My research days are gone. Just having a lot of clinical experience with brain stimulation. And I find it works much, much better in older patients, also in adults, and also older patients after the age of 60. We see much better results with plasticity. And if you're going to use it for minors, also for teenagers, for adolescents, the brain is already very, very plastic at that age. So, I mean, you don't change much by stimulating it. You can teach. I'm a psychotherapist. I like to work that way, but I find from my experience, brain stimulation works wonders in older adults.
That's an excellent point. And I know there are studies that they might contradict each other, as everything in research. And I do get often the question about, oh, this is an old person, so they might not receive any benefit, but you're absolutely right on the contrary.
Actually, we treated patients with dementia, for example, or with depression, and also with cognitive deficit, which is close to the pathology of ADHD. You have the cognitive aspect, and we see great improvement.
Exactly. I've got patients with Alzheimer's as well, and they have shown good improvements. At least stability of their symptoms, which is very important when we discuss dementia and Alzheimer's. And there is systematic review and meta-analysis on that. So it's not just one RCT or one non-double-blind study.
So we have still 5 minutes for some questions that are online.
Excellent.
Because we have a lot of people in Europe watching us today and hearing you speak. There were certain questions about neuroplasticity. Is it a lasting thing? Is there any, how do you measure the neuroplasticity? Okay. One of the questions is neuroplasticity. Does it last? And how do you measure neuroplasticity? Or is it just something you know? Did you test it with mice or something? How do you know?
Okay, so obviously if we're talking about something and in regards to neuroplasticity, there are studies done in animals, as you said, and we can see neuroplastic changes in mice. We can see neuroplastic changes happening as well if we're trying to do, let's say, a functional MRI or perhaps PET, or trying to understand how the synapses in the brain are, or using EEG, for example, to try and see if there are any changes, positive outcomes are happening from stimulation. And in terms of measuring it, is such a difficult task. We don't have great means of measuring neuroplasticity and neuroplastic changes. In research, perhaps, there are some findings that are suggestive that we do see these neuroplastic changes happening, not clinically, unless we use some cognitive testing and we can see that perhaps in dementia or some tests that someone has improved or remained stable. Also, what's important, if you learn how to play violin, you should try on and continue to play the violin, because you will forget all about it. So in the same way, I would say that neuroplasticity will continue to happen, but we will need to continue and providing intrinsic and extrinsic factors to our brains.
Then another question was, do you know other European countries where TMS is used or available, small scale, large scale?
Yeah, sure. Actually, it's available in a lot of European countries. And there are also manufacturers of TMS devices, such in Denmark, the Scandinavia, they have their own devices there, Germany, UK, Czech Republic have their own manufacturers of TMS device. There are also, we can see devices coming from all over the world, from the States, from China. And these devices are used throughout Europe, throughout the world, I shall say. So it's not something that is localized in Cyprus or UK or the States. TMS is available in most countries, I shall say today. It's available mostly for the FDA approval treatments, but off-label treatments we can see happening in the UK and in other countries as well.
Okay. These were the questions online. At least I picked a few from them, and due to time reasons, we have to stop. So if you don't mind, I sit here. But thank you very much for sharing all this new knowledge with us, and a small present for you just as a gesture.
Thank you so much.